And then Nissy, am I able to forward, or do I just tell you next slide?
However you want to do.
Oh, okay. I can go ahead and move forward.
Nissy's gonna have to move it forward.
She will, okay. Okay, we'll go ahead and get to the next slide. And those are just the disclosures that we talk about. I am a part of our Ryan White funded clinic. And I think we've probably talked about it before, but just for the new people joining today, we are Ryan White funded. And in the state of Oklahoma, there are 2 Ryan White HIV funded clinics. One is located here in Tulsa, and that's us. And we cover the eastern half of the state. We're a little over 1,300 patients. There is also one in Oklahoma City, and they cover the western half of the state, and it's a little over 1,600 patients. There's over 5,000 patients living with HIV in the state of Oklahoma, and although some may be seen outside of a Ryan White system, there are still patients that we're trying to get diagnosed, get into care. But what we do through Ryan White's is very important for the state of Oklahoma. And particularly, we just had the Ryan White conference a couple of weeks ago, and the viral load suppression rate through Ryan White clinics has continued to rise as what we're doing to keep patients in care and virally suppressed continues to improve, and I believe was up to 86%. And so anyway, we are part of that Ryan White funding, and that's where a lot of our cases that residents are presenting are through our Ryan White clinic. We also have a residency program affiliated with us through OSU, and that is our internal medicine program, and they get to train through our Ryan White funded HIV clinic, so they get a lot of experience with HIV. And that's what I did 13 years ago when I went through this program, learned about HIV, and then I didn't see it for a while. And I was a hospitalist for several years with the local hospital, and then came back to the program. And so what we're always looking is to teach other providers, new providers, so that we have more providers in the treatment of HIV. Our providers themselves are an aging population in terms of treatment of HIV, and we're always looking for providers. And in Oklahoma, that has been the case. We have a lot of providers that have gotten close to retirement and no longer practicing for the treatment of HIV. And so we're always trying to teach new people that would be able to then go out and be able to treat HIV. Next slide. Okay, no other disclosures there. We'll move to the next slide. Okay, so what we're going to go over today, we're just going to talk about screening for some of the barriers to care. So through Ryan White clinics, we are checking for certain barriers that are probably the most common when we look at patients that are in treatment or trying to stay in treatment. And so we'll discuss those today. We're going to talk about preventative screenings. And so I'm going to talk about preventative screenings for women in terms of cervical cancer as well as breast. And then we're also going to talk about anal screenings as well as colon cancer screenings. We're going to talk about what grade of recommendations those are and what recommendations are currently in place. Also in terms of sexually transmitted infections, osteoporosis, other sexually transmitted infections, including syphilis, which has been fairly high in the state of Oklahoma, and so something that we see really on a day-to-day basis. We'll also talk about routine screenings for tuberculosis and hepatitis, routine screening for lipids as well as diabetes, and then preconception counseling and contraception. So definitely if you're doing primary care along with treating HIV, many Ryan White clinics, a lot of times we're the primary care provider for these patients as well, then all of these things become important. Next slide. So this is the IDSA guideline set, primary care guidelines in the management of persons infected with HIV. And in 2013, this update came place. And like I said previously, there's an update that we are still awaiting, and I think may have some delays due to COVID. We're still waiting on an update on this set. So we're going to review what have been the guidelines that we've been following thus far. So our screening questions through our Ryan White Clinic, most of the time what we're trying to elicit are barriers, most common. And a lot of what we find is mental health barriers. So in our clinic, what we do, initially we used to just screen, hey, are you having any mental health problems? Do you have any depression? Do you have any anxiety? But we've actually incorporated a patient health questionnaire, and you may be familiar with the PHQ-9. A couple of years ago, got funding for a collaborative care project, and this is doing depression screenings and treating for depression in patients who have HIV. And as we did that, we decided to actually screen all patients through our HIV clinic with the PHQ-9 questionnaire. And in our clinic, it is actually handed to the patient by the front desk so they can fill it out in the waiting room while they're awaiting their rooming process by nursing. They hand the results to the nurse, who will then add it into our electronic medical record. And then it is available for the physician to review when we see the patient. And so that's part of how we do screen for mental health. A lot of times also screening for substance abuse, and sometimes those two things can go hand in hand, sometimes they don't, but we do find that both of those two things are common barriers to patients getting into treatment, or if they're in treatment, staying in care. Also nutrition, and sometimes we forget about this one, but sometimes patients don't have access to food, and now that as we're more in an integrated world, maybe that may not be always an issue as needing food to be able to take the medication, but we still have patients who are on medications that are boosted or that are protease inhibitors that still require food for absorption of those medications. And if a patient doesn't have food, we have to be able to think about that as a barrier. Other barriers that come into play, transport. And so recently at the Ryan White conference, I presented our telemedicine program, but this is something that we offer for patients. Remember that we're covering the eastern half of the state. And so there can still be patients that are driving 2.5, 3 hours to get to us to get into care. So we do have a telemedicine program that we offer appointments through in McAllister as well as Poto to try to alleviate transportation as a barrier. Housing, we work hand in hand with Tulsa Cares. They have housing assistance that they can provide to patients. And Tulsa Cares is one of the not-for-profit organizations in town helping patients with resources for patients who have HIV and now hepatitis C as well. And then other barriers can be culture, language. We use a language line in our clinic because we do have patients, oftentimes the languages that we're using the most seem to be Spanish as well as Burmese. Actually have quite a few Burmese speaking patients, and we're able to utilize the language line in case they're not able to bring a translator with them, so we can still conduct their appointments. Next slide. So just the recommendations in this guideline set for cervical cancer screening. So it was a strong recommendation in this guideline set to screen every 6 months during the first year of diagnosis and then annually thereafter. And I don't know about some of the clinics that you serve, but it can be a challenge. It has been a challenge for us, and talking to other clinics can sometimes be a challenge to get women to come in annually to get this screening. But it's so important because the risk of cervical cancer is increased in women with HIV. Our clinic is about 19% female, and some of those may not necessarily be of childbearing age, but it's still important that we're doing these screenings. The recommendations were also if there were 3 consecutive negative paps that we could then change that screening to every 3 years. What we do include on ours, and it was recommended to include not just the cytology, but HPV screening and STI testing, to include gonorrhea, chlamydia, as well as trichomonas. So we do all of these things on our pap testing. And then if there is abnormal cytology or high-risk HPV, remember the recommendation is to refer to OBGYN, or basically need access to the patient getting a colposcopy. And for us, it is usually going ahead and recommending a referral to OBGYN for that process. Next slide. So next I wanted to talk about anal paps, and we do anal paps through our clinic, but on this guideline set, it was actually a week recommendation. And I know there is the anchor study that's ongoing at the moment, and we're looking at whether doing anal paps and doing whether it's ablation or doing things like topicals, such as Condolox or Aldera creams, imiquimod, can make a difference for these high-grade dysplasia that we see sometimes come back on these anal paps. But currently, the recommendation was a week recommendation to do the anal paps. We screen annually for them, and we're looking for patients who are MSM, or men who have sex with men, women that are participating in anal receptive intercourse. So it's important to remember them as well as needing screening. If someone's had that abnormal cervical pap smear, that can go hand in hand. Patients who have had genital warts, also screening for anal HPV. So, our human papillomavirus. So we're screening, and most of the time, most of our screening are patients who are MSM. We're trying to screen those annually, and just like on the cervical paps, we're screening with cytology, HPV, and then also gonorrhea and chlamydia. The interval of screenings was not defined on this guideline set, although we are performing those annually through our clinic. And again, hoping that as they do an update on this guideline set, that there will be further guidance for that. Remember, the pathology similar to cervical pap. So if we find an abnormal cytology or a high-risk HPV, referring to a colorectal surgeon, or basically having the means to get a 4-quadrant biopsy. For us, that's our general surgeons. They have an anoscope and do quite a few of our follow-ups of our anal paps. And so we actually refer to our general surgeons, but if your general surgeons are not familiar in the area, maybe a colorectal surgeon that you need to refer to. Next slide. So sexually transmitted infections, this is very important. This was strong recommendations, what we're gonna go over here, and screening for gonorrhea and chlamydia at the initial presentation and then annually if at risk for infection. And many of our patients are at risk. And so what we have actually instituted through our Ryan White, we had a site visit, it's been about 4 or 5 years now for our Ryan White funding. And they actually recommended that we provide annual screenings. And we thought, oh, initially we are providing those annual screenings because whenever we do a cervical pap or an anal pap, we're getting the screening for gonorrhea and chlamydia. But remember, then we weren't really checking urine gonorrhea and chlamydias at that time, so we weren't getting that screening. And if a patient didn't follow up for an anal pap or didn't get their cervical pap, which we know sometimes happens, then we still weren't getting that screening done. So we actually ended up instituting just checking a NAT test, or the urine GC chlamydia, annually with our other annual labs that we'll talk about here in a bit. And we actually found that we were diagnosing a lot more sexually transmitted infections, even with patients that were asymptomatic, and we're able to treat those. It was also recommended in this guideline set that all women less than age 25 should be screened for chlamydia. All women should be screened for trichomonas. And if positive, that we should actually be retesting within 3 months due to high reinfection rates, not necessarily to check for clearance of the infection, but that those high-risk behaviors may still be there that may be putting them at risk, as we've seen with other sexually transmitted infections such as syphilis. Screening can be obtained with all of these different parameters, but remember that we don't want to forget also doing throat swabs, because that is just another orifice that may also be positive for gonorrhea or chlamydia, but then also urine, cervix, and the anus, like we've discussed. Next slide. So they talked about some other screenings as well, and some of these screenings are different than what the United States Preventative Services Task Force would recommend for all patients, and some are the same. In terms of mammography, it was the same. It was a strong recommendations to annually screen women over the age of 50 with a mammogram, but if women were between the ages of 40 and 49, we needed to assess risks for breast cancer, have that discussion with the patient about risks and benefits, and then decide. Next slide. Colonoscopy, same whether you have HIV or not. The recommendations following the United States Preventative Services Task Force guidelines, screening over the age of 50, may want to increase that screening in patients who are African American, maybe starting to screen at the age of 45. And then remember, this is a screening, so if somebody has a family member that's been at risk, that changes the screening guidelines. Next slide. The DEXA scan, so this has come up a lot in terms of screening for osteoporosis. As we know that some of our HIV medications do put patients at risk, particularly our new backbones can actually decrease our bone mineral density and can place patients at a risk at an earlier age. So these guidelines are different than what is recommended for a non-HIV patient. It was a strong recommendation to get a baseline DEXA screening for osteoporosis in all postmenopausal women and in men over the age of 50. We talked about the nucleosides. Reverse transcriptase inhibitors can decrease that bone mineral density, so that can put patients at risk. And remember, if you still have patients on TDF or tenofovir disoproxil fumarate, that they may be at greater risk than patients who are on TAF, which is our tenofovir alafenamide. Next slide. Strong recommendations in terms of labs. So this is important if you're a primary care physician taking care of HIV, and if you are doing routine screening of labs, then this is very important. And so the recommendations were to obtain a lipid panel prior to initiation of antiretrovirals, but then you also want to reassess that once you've started the antiretrovirals, so within 1 to 3 months after starting antiretrovirals. Same with the hemoglobin A1C at initiation and 1 to 3 months thereafter. After ART. And then usually what we'll do with these is then annually we do check lipids and A1Cs on patients. On the RPR, similarly, initiation at care, so we do it on all new patients, and then it says periodically thereafter. In our clinic, because we also have Ryan White guidelines that we have to follow, we are required to screen annually with the RPR, and so that is what we do through our through our clinic. Previously, if positive, we used to refer to the health department. We've recently obtained penicillin in our clinic and are able to treat syphilis through our clinic as well. TB testing, so our screening with quantiferons or any other type of IGRA, or using a tuberculin skin test. All these were still in the guideline set as potential alternatives to using a quantiferon at initiation of care, and repeat once a CD4 is greater than 200. Because remember, even with our quantiferons, we may get an indeterminate if that CD4 is low, rechecking it once that CD4 is improving. Remember, if positive, they'll need a chest x-ray, and we're sending them to the health department as well. Remember, sometimes patients have been treated for latent tuberculosis, and remember that quantiferon test can continue to be positive if that was previously positive, depending on where they're at in that continuum of that quantiferon, but you only get a negative or a positive test or an indeterminate. So on those patients, then I will annually screen with a chest x-ray, but if someone has not been positive on the quantiferon, we continue to test with that. We don't really use the tuberculin skin test anymore. Found that it was cumbersome having patients to come back within the 48, 72 hour timeline to get the test read. It was very difficult. A lot of times we would fall out with TB screening. With the quantiferon gold, it has become a lot easier, and we're able to do that. We do that test annually through our clinic. And then hepatitis panel, back one slide, okay, perfect. And hepatitis panel, just an initiation of care. So we do that at baseline, right? We wanna know their hepatitis B status prior to initiating antiretrovirals. I think we discussed a little bit last time. And then a few times before that, we did have a didactic session on hepatitis B. So remember, we always want to know their hepatitis B status. If they are hepatitis B positive, it's important to know their hepatitis B viral load, especially when they're on treatment with HIV medications, because many of those medications could also be treating that hepatitis B. And some have cleared the hepatitis B and may have a viral load negative, but may still show antibody. Also, it's important to know at entry of care whether they were vaccinated and whether they have immunity. So oftentimes I will ask them if they have vaccinations. Sometimes patients know, sometimes they don't. Sometimes we can figure out just by their age that yes, they had to get those vaccines through schooling. But either way, we'll usually check for immunity for hepatitis A and B, so we can determine if we need to revaccinate those patients. It's important to do that initially at entry of care. Remember, again, if they're positive for hepatitis B, to check that hepatitis B viral load. Next slide. Reporting in FIDO, and I know this isn't necessarily very clear, but you can find this, it's the reportable conditions or diseases that are to be reported in FIDO. And there's a number there for Oklahoma. But some of the reportable conditions I've put there on the bottom. So we want to remember sexually transmitted infections, TB, syphilis, gonorrhea, chlamydia, of course, a new HIV test, as well as hepatitis and TB. Next slide. So contraception and preconception. So this is important, and this also came up in our screening, or our site visit that we had a few years ago with Brian White. They were wondering what we were doing in terms of contraception for female patients. Again, you know, like now it's about 19% female through our clinic. So, and some of these, out of that 19%, not all patients are childbearing age. But the ones that are, it's important to do preconception counseling. And so we actually created a dot phrase that we put into our electronic medical record, so that if a female patient comes in, we can actually do this screening. And we can put in there if it's a patient that's not of childbearing age, but if they are, then we ask some questions about whether they're wanting to have a child or what type of contraception they're utilizing at the moment. And if they're not, then we can have a further discussion about that. If they are interested in having a child, then again, having a discussion about that. But being able to know where they are. So this was a strong recommendation in this guidelines that to be doing this with your women of childbearing age that are HIV infected, their plans of whether they want to have a pregnancy, if that's going to be now, if that's going to be in the future, so that you can also make sure they're on correct antiretroviral, and then also making sure that they're in care, so that when they do become pregnant, in our clinic, we monitor them monthly during pregnancy, so we can make sure that they get to undetectable and stay undetectable. You want to have the conversation of contraception if they're not interested in having a pregnancy. And so this is important as well. You want to know their partner status. So males or females, most of the time when I'm having this conversation about making sure we're using condoms, etc., I will actually just document in there if they have a current partner, what is the status of that partner? Are they on PrEP? Are we using condoms? You know, those types of things. And so it's a good place to start that conversation, and then go ahead and talk about condom usage and protection. Disclosure of status to partners. I also use that time to discuss that, particularly with new patients coming into the clinic, to making sure they are disclosing status. And then the importance of viral load suppression during pregnancy is important. And like I said before, we see them monthly. I use that time to educate my pregnant women about not breastfeeding during their after delivery, and I use that time during the pregnancy at every appointment to remind them that we will not be able to breastfeed. Next slide. Just another way to look at our labs. You know, most of the time we're seeing patients every 3 to 6 months when they're virally suppressed. And we're getting that CD4 viral load, CBC and CMP all within that 3 to 6 month period. But then every 12 months, the labs that we discussed, and we're checking a lipid panel, an A1C, syphilis testing, quantiferon, hepatitis panel, and a urine GC chlamydia annually on all. Remember, you may need syphilis testing and gonorrhea chlamydia more often if you have high-risk patients or if they have been infected before and treated. And vitamin D levels, we don't follow them annually, but we do check those at entry up here. Next slide. So just conclusions and clinical pearls. What did we talk about today? Cervical paps, we basically recommend doing an easy way to remember it is just annually. These patients are going to need it annually because they're at greater risk for HPV, which puts them at greater risk for cervical cancer. Anal paps, we talked about, it was a weak recommendation in the guidelines. We're awaiting the results of the ANCHOR study, the ANCHOR trial. So remember, same pathology, increased HPV puts them at increased risk for anal cancer, which is what we're trying to prevent with screenings. STI screening annually more often if it's patients at risk. Mammogram and colonoscopy, no change than patients without HIV. But there is a change for osteoporosis doing DEXA scans like we talked about over the age of 50. Remember, preconception counseling, contraception, and partner status important, at least to be doing this annually, if not more often. And remember to screen for those barriers, mental health, substance abuse, and nutrition. But don't forget about transport as well as housing and some of the other barriers I'm sure all of you are familiar with as you're treating patients with HIV. Next slide. I think that's the conclusion, just my references as we use this IDSA guideline set. Please, if you haven't looked at it before, it's actually a really easy read. That was a quick summary of what's in it, but there's a little bit more information. It really is good to look at, but hopefully we will have an updated version of that really soon. I'm happy to take any questions or comments at this time, or I'd love to hear what you all are doing in your areas, especially we have some people on from that are practicing in different states. I'd love to hear what you guys are doing in some of these screenings. So happy to take any comments or questions.